Hey guys, welcome to this pharmacology review on the drug class monoamine oxidase inhibitors within the drug category antidepressants. I'm Dr. Busti, your faculty and host on This Is Why, a show that helps healthcare professionals transform their medical knowledge from knowing just the what to the why. You know, monoamine oxidase inhibitors merged back in the 1950s. That was a long time ago. And there was a lot of initial excitement in the area of neuropsychiatry, but like many things, they make their way to the market. Post-marketing reports related to side effects and issues related to relevant dietary restrictions started to emerge and raise safety concerns. And so their use slowly started to decline as newer agents started to emerge. Well, those newer agents included the TCAs, which again, began to raise safety concerns in their class related to things like QT prolongation, causing life-threatening ventricular dysrhythmias on occasion, especially in overdoses. But it wasn't until the SSRIs finally hit the market where these drugs and TCAs, monoamine oxidase inhibitors, really started to decline. You know, my 30 years working as a nurse, pharmacist, physician, and even teaching in academia, I remember thinking, wow, I see these agents all the time in warning statements, drug interactions. And I made a mental note, avoid these agents. But really it shouldn't be that way, right? If they do have a relevant place in clinical practice even today, but they have to be used correctly. So if I had to figure out how to use them correctly, it required me first to understand why I would even use them and when. Now remember, learning to understand enables us to make complex medical decisions much clearer. And that's what we're going to do here in this drug class so that you don't have to be afraid of them just like I was back in the day. All right, so given this, the obvious question about the monoamine oxidase inhibitor is, then why are we using and studying this? Why is it relevant? Well, there are times when drugs of choice that we use today, that are the accepted standards of care and practice for a particular medical condition, just don't work for a patient. We need to sometimes reach into the bag and find something else. And so patients with severe or what we would consider treatment-resistant depression, we need some options. And this is where this drug class really can fit. Again, if used correctly, it can be a good treatment option when other treatments are not providing the adequate response that we're looking for. Okay, so now we need to talk about what medications make up this drug class and what are their uses? So I like to use tables. If you've seen these topic reviews, I know that this information in the table is a lot, and the slide or the image is quite busy. That's okay. Just soak it in. Let me just walk you through the content. Okay? We do make these tables and images available at thisiswhy.health. You can go over there and sign up for a free account, and you can have access to other things like collections, playlists, ability to bookmark, but also download tools like this if you need it for studying, share with your colleagues, even for teaching purposes if that's what you need it for. Okay, so let's walk through some of the components of this table. On the far left side, you can see the names of the drugs, and yes, we will focus predominantly on the generic names. Now, this drug class is not used very much, so these are some of the drug classes that sometimes people put to the side. You have to memorize some things, that's okay, all right? That is what it is. But it is important to recognize they still do exist. And I listed for you under each generic name their historical or brand names, even though many of them are not available. Again, we do that just to provide a complete picture, put in a little bit of the historical context in there as well. So that's the first column. The second column that you see are the indications and common uses. And of course, major depressive disorder is there. That is known. What again helps us to decide and why we pick a certain drug class in the category of antidepressants, or within inside of a drug class, why we pick one agent over another. Sometimes it's down to the indication, where the evidence lies, where the improvement in response is noticed greatest in clinical practice. Sometimes it's side effect profile. Sometimes it's a dosage formulation, okay, that drive those decisions. So you see that treatment-resistant depression is clearly listed there. All right, that's important. I've mentioned that already. That was one of the uniques of why we study this. We need to be able to reach into the bag and still treat patients when they're not adequately responding. Social anxiety disorder, specifically phenelzine, right? You can see Parkinson's disease has two different dosage, Parkinson's disease has this dosage form of Selegiline that it's used for, and that's the oral form. The transdermal patch, also known as MSAM over here for Selegiline, that is the one that is used in depression. So the oral is for Parkinson's disease, the transdermal is for depression, okay? So that's why I wanted to point some of those things out. Those are what are some of the subtle notes that are on these tables that can be helpful at distinguishing the nuances. These also become common test questions for board exams and for your classes. So pay attention to some of those things, all right? So we have isocarboxazid at the top there, phenelzine, Selegiline. Probably Selegiline is the one that's going to be talked about most because MSAM's emergence over the past several years, and it's been around for a while, but it's the one that commonly shows up, okay? And then phenylcypromine is the other option in there. Now, if we look over onto the far right portion of the table, there's the clinical pearls. And again, try to put in there some of these things that we're going to talk about. But again, most of what you see, especially in the first bullet here, is these are typically reserved for resistant depression. Then there's a bunch of issues related to how you use them, drug interactions, and these are some of the things that I'm going to bring up. But what's great about this class compared to the TCAs is we don't have to worry as much about the QT prolongation. I mean, thank goodness, right? So now let's take a moment and let's talk a little bit about the mechanism of action. Okay, as it relates to the mechanism of action of antidepressants, we're going to just think about it as a class, a category. There's a lot of things happening in the central nervous system. There's a lot of nerve fibers that are talking to each other in different tracts in different regions of the brain. And this is part of the reason why some drugs, when they modulate the activity of one track, we see a benefit or an effect in a certain type of condition, but if we isolate that effect in another track, we don't see the same. So that gives us some variability, and that's why you see some indication variation inside of the drug classes of the category of antidepressants. So for example, SNRIs and TCAs, which mechanistically are similar, can treat some pain syndromes. You see that common shared thing, whereas SSRIs, selective serotonin reuptake inhibitors, we're not using it to treat pain. It's mostly anxiety, depressive disorders, those kind of things. And so let's step into what's going on inside of the brain at the central nervous system where these drugs are working. So what we see over here are two neurons interacting, okay, and then they usually communicate obviously by an axon, and in between their connection points is a synapse, or synaptic cleft is what we refer that to. So this picture that we're looking at larger is kind of zoomed in on this region right here. We have the presynaptic neuron where the impulse is coming down from the axon, it then facilitates intracellular and chemical reaction that facilitates the emptying or the release of neurotransmitters. So you see these vesicles that are floating around in the presynaptic neuron, and those vesicles are holding on to neurotransmitters. And those neurotransmitters are the serotonin, norepinephrine, and can also include dopamine, okay? And so we have different vesicles for different neurotransmitters. This drawing a diagram doesn't necessarily reflect the difference in those, but just recognize that those are the neurotransmitters housed in that. Well, you see that calcium is necessary, its influx in facilitates the binding and the merging of the vesicle at the presynaptic neuron to empty those neurotransmitters into the synaptic cleft. What's the purpose? To then stimulate the postsynaptic neuron that's going to drive the impulse to the next neuron as it propagates through the system. Now, you see on the postsynaptic neuron in the synaptic cleft there's a number of receptors, and these are receptors that drugs can bind to directly. So we have some drugs that act as agonists to these receptors. And you see that these neurotransmitters get in and then they turn on and create the propagation of the nerve impulse moving forward through a number of different mechanisms. There's a lot of different types of transporters here, okay? Now, when these neurotransmitters get released into the synaptic cleft, yes, they can bind to these transporters and turn on and propagate the nerve impulse, but they can also be taken back up by the presynaptic neuron. So that's where reuptake occurs. So when we think about these SSRIs, serotonin selective reuptake inhibitors, those drugs would prevent the reuptake of serotonin neurotransmitters. Well, what would that do? That would leave more serotonin neurotransmitters present in the synaptic cleft to exert more of a pharmacologic effect on the postsynaptic neuron. So you can have, the release of it and then the reuptake of it. There are enzymes present that are not seen here, but there are enzymes present in the synaptic cleft that can metabolize or degrade the neurotransmitters, make them go away, right? So you can take it up and take them away. You can metabolize them and take them away. Or they could go in and bind to the receptor and be occupied and are no longer in the synaptic cleft. Lastly, we do have other presynaptic receptors that are not seen here, but let's just envision like there's an alpha-2 receptor presynaptically up here. Well, there's drugs like mirtazapine that functions as an alpha-2 antagonist, okay, that is, and the antagonism of that actually increases the release of neurotransmitters. So some drugs work to facilitate the release of neurotransmitters. Some drugs block the transporter uptake, and some drugs like monoamine oxidase inhibitors block the metabolism of neurotransmitters found in the synaptic cleft. If you co-administer multiple antidepressants, that is when we can see an accumulation of neurotransmitters in the synaptic cleft that raise the concentration so high that patients now can experience greater risk of side effects. It doesn't mean they all will. Sometimes we do use augmentation or adjunct therapy with dual antidepressants from different classes to manipulate the concentrations of neurotransmitters, but it does increase, obviously, the side effects. When we think about the monoamine oxidase inhibitors, that's an enzyme. And monoamine oxidase metabolizes several neurotransmitters in the brain. So let's go back to the synaptic cleft. If I block monoamine oxidase that's present out here, then these neurotransmitters can be present at much higher concentrations. Well, the thing that's about monoamine oxidase inhibitors is it's irreversible inhibition. For the life of that enzyme, it's gone. So the body has to make more monoamine oxidase enzyme before it can come in here and start to metabolize that more effectively. That's the reason why we have to wait 14 days after stopping the monoamine oxidase inhibitor before starting another class of antidepressants. If we don't, then that enzyme is not working and we increase the concentration in the synaptic cleft, that's going to exert a more noticeable effect by those neurotransmitters. That could be good, could be bad. In this case with monoamine oxidase, we do not recommend doing that. But that makes sense of why we need to wait a period of time. Think about antidepressants and you're going to switch to a different class, like monoamine oxidase. You wait 7 days. You want to make sure that drug is gone, especially with high-risk medicines. Now again, some medications can be used in augmentation on purpose, but that's usually done by specialists and in careful scenarios. But we do want to watch out for that because of risks of things like serotonin syndrome and other things. You can lower the seizure threshold. Any drug that increases norepinephrine in the synaptic cleft is known to lower the seizure threshold. And so when you look at things like drugs like bupropion, right, even venlafaxine, desvenlafaxine, that are going to raise that norepinephrine up as well. Tramadol, which has some SNRI-like activities. All of those drugs modulate, influence the neurotransmitters present. So when we study the drug classes inside the category of antidepressants, we need to have this frame of reference. Are we increasing the release, like mirtazapine is doing? Are we preventing the reuptake, like SNRIs, SSRIs, right, tricyclics? Or are we blocking the metabolism of the neurotransmitters, like our monoamine oxidase inhibitors? Okay, I hope the mechanism made sense, but really thinking about the unique mechanism of this compared to a lot of the other drugs that really are targeting receptors or transporters, the monoamine oxidase inhibitors are focused on an enzyme that metabolizes neurotransmitters. And so what we've tried to provide you are the target neurotransmitters for these drugs in this particular table. And you can see that monoamine oxidase inhibitors, they are irreversible. So they form a covalent bond with it. They irreversibly bind for the life of that enzyme. It's out, non-functional. And there's two, again, types. Remember that monoamine oxidase A and B. And those enzymes are important for the metabolism of neurotransmitters serotonin, norepinephrine, and dopamine. And so what basically happens is that it prevents that degradation in that synaptic cleft, whereas a lot of the other antidepressants are working again on preventing the reuptake of those neurotransmitters or inhibiting the reuptake and binding to another receptor. Those are the small things that make them different, but it starts to make sense why we have to be very careful if we co-administer another class of antidepressants while this enzyme is not functional. Because if it's not functional, then the concentration of those neurotransmitters can be raised in the synaptic cleft to very high levels. That can lead to side effects, complications, serotonin syndrome, other things like that. And so we don't want to neglect that. Now, the irreversible nature here, I want to talk about this for a second. This is important because when you think about pharmacokinetics and dynamics, this is obviously a pharmacokinetic issue, that these drugs will stay around for a long time. Their effect, biologic effect, stays around. Maybe the drugs are gone, but the biologic effect is still there, okay? And so that matters because when you're trying to switch somebody from one agent to another, depending on the order that you switch them, influences the time frame or interval of which you make the switch. So for example, if they had been on a monoamine oxidase inhibitor and you were switching them to a different antidepressant, well, that's when you typically are going to wait 14 days. Why 14 days? Well, because that's going to be about how long it takes for the body to regenerate and make more monoamine oxidase enzyme to be present. Secondarily, if they are on another class of antidepressants and you're switching to a monoamine oxidase inhibitor, typically you can wait a shorter period because most of those drugs wear off much more rapidly. They're not irreversible in most cases. And so 7 days is typical period before starting the next medication. That goes back to the mechanism. The exception is if you have someone on fluoxetine, which has a much longer half-life because of its metabolite, norfluoxetine. Very long, sticks around for a long time. So you don't want to co-administer these or overlap them too much because of that, because of this mechanism, which then impacts these neurotransmitters in a significant way that can lead to side effects and complications. All right, so when we put the monoamine oxidase inhibitors in the context of the other subclasses in the antidepressant category, you can see down here is where they reside here compared to, we have the SSRIs, the SNRIs, atypicals, tricyclic antidepressants. They all pretty much have good clinical efficacy. Now again, monoamine oxidase inhibitors have been around a long time. Their use has declined significantly, so much so that even studies that evaluated some of these just don't have enough data to give us good information in the context of here. But side effects can be high, especially if administered wrong with another medication, or like we're going to talk about here in just a little bit, dietary issues that show up. Okay, so it's really reserved for that last line effort, patients with treatment resistance, they're not responding to other things, or they're having drug interaction side effects that warrant them to switch to something else. But we just put this together for you to give you a little bit of a, just again, high level comparison on how they kind of fit. Because a lot of times what drives us to pick an agent is, yes, certainly cost, access, but side effects, indications, like we've been talking about, evidence. And in the area of neuropsychiatry, man, it is hard sometimes to predict who's going to respond to an agent more so than another. Okay, so now let's take a moment and let's talk a little bit again about side effects. We've already started to slowly introduce that concept here. Obviously the tolerability, what are we worried about with monoamine oxidase inhibitors that caused that decline? Again, a lot of it has to go back to some dietary issues, and then of course the co-administration of medications that affect the concentrations also of neurotransmitters. That's where the issues sort of start to show up. Now, between the agents, you can see it as just a quick overview. They all look relatively about the same. So when it comes to anticholinergic effects, GI side effects, the risk of hypotension. Now, the hypotension that's listed here, okay, this is in the, again, the context that you're not co-administering something else, okay? That may not make as much intuitive sense in the brain, but it does affect some neurotransmitters in the periphery. And so we see the same similar problem in patients with Parkinson's disease who get monoamine oxidase inhibitors, Selegiline and rationale, and so that still shows up also over there as well. Insomnia, because of the excitatory nature, especially with the norepinephrine. Sexual dysfunction, again, weight gain, typically not too much of an issue. Now, there's a couple small things compared within the agents that we should look at. One is that isocarboxylate is, possibly there's been reports of vitamin B6 deficiency. That's, again, case reports, doesn't prove causality. but it is something that shows up as one of those kind of other side effects monitoring parameters. Phenelzine is pretty cost effective. When you look at Trenylcypromine, this is one that includes the use in panic disorder, social phobia, and migraine prevention in some patients. And then we have the Selegiline or MSAM formulation again, which is the transdermal patch formulation. You can develop some irritation at the site of application. And then this is interesting. It does get metabolized to a metabolite that mimics the amphetamines or stimulants. And so urine drug screens could create a false positive for that. And again, that would be a drug lab interaction that is worth paying attention to, especially, specifically for patients who have to get random drug screens for their job or for some other reason. We don't want to inappropriately accuse them of anything. Okay, so just like all medications, we talked about brand name, generic names, their indications, mechanisms, some of their main side effects, which we can see that there's not that many big differences between them. But what about some of the things that might be enough of a warning to even consider avoiding its use or being a contraindication? Well, one is obviously the concern about suicidality. That's true for all the antidepressants. I mean, we can change someone's mood and give them enough energy while they're still depressed and suicidal, but they don't technically have the energy to carry it out, but now all of a sudden you do give them the energy to do so. Another patient population that you might want to be very careful to avoid these drugs in is someone with pheochromocytoma. That is a tumor essentially where the tumor is producing catecholamines. So when you have an enzyme inhibitor like monoamine oxidase inhibitors that are irreversible, you could cause significant changes in the hemodynamics in patients. So that becomes an issue, especially patients with uncontrolled hypertension, not just with pheochromocytoma, but just in general uncontrolled hypertension. Okay. Now you also heard that hypotension was concerned. So patients that have low to low normal, blood pressure, they need to be watched. So we typically reserve these drugs for otherwise relatively healthy patients who have treatment-resistant depression. Now, as I mentioned earlier, if you are going to initiate another antidepressant class, you have to wait 14 days after stopping the monoamine oxidase inhibitor because of its irreversible enzyme effects. So it just takes that long for the body to remake that enzyme. Okay, what about the drug-food interactions? Let's look at another table in more detail so that we can talk a little bit about what are some of these things, because they become important counseling points for our patients if they're going to be put on them. Okay, so what we put together are some of the medications to avoid. Okay, so drug, and then we'll look at the drug-food. So drug, again, many of these are going to increase the risk of hypertensive crisis, or they're modulating the effect of neurotransmitters, specifically serotonin, that puts you at increased risk of serotonin syndrome. So this table here is a great study tool. Can also be very helpful for medication use evaluation efforts if you have patients on these medications. Because you should be scanning their med profile, looking for drugs in any of these classes or individual agents that would potentially do that. And if you look at many of them, they're modulators of the neurotransmitters or work in the central nervous system. Okay, and so that makes them sort of the consistency of what you see and why there's concerns. People don't always recognize that. Yes, most of these drugs work in the central nervous system, but we also have two agents that are antimicrobial drugs that have monoamine oxidase inhibition properties themselves. And so you don't want to co-administer drugs with the same mechanism. So tramadol would be another one that's kind of weird. It's an opioid, but it also has basically a little bit like some SNRI-like activities. and so it can raise the concentrations of serotonin as well. So just keep this list in mind. There's a lot on here. I'm not going to read them all to you, but it's again a good study tool. Okay, as it relates to drug food, what I've tried to do here, these are the drugs that contain tyramine. Tyramine is going to be one of those precursors to some of these neurotransmitters that are going to feed the system and make those neurotransmitter concentrations go up and would increase the risk of a hypertensive crisis or an acute rise in their blood pressure. And certainly if patients with underlying cardiovascular disease, heart failure, uncontrolled hypertension, this would be really bad. So we try to break it down on the left side as kind of the food categories, if you will. You see things like dairy products, especially fermented and aged. You got the meat and fish products here, again, aged, cured, dried. Soy-based products that are fermented, in particular in process. Fruits, especially again, those that are pickled or fermented. You see a sort of theme there. Certain vegetables, and then even certain drinks, okay, that we want to be cautious about. So then on the right side, within those categories, we try to list some of the practical items that make up that category so that people know, like, well, what are you talking about? So dairy products, it's like aged cheese. Cheese is up here, like cheddar, Parmesan, okay, buttermilk, right, that kind of stuff. Preserved anchovies, smoked salmon, dried or cured ham, sausage. Okay, you see a lot of the soy sauces over here. Okay, those can be problematic. Avocados, especially the ripe ones. Pickled fruit like cucumbers, peppers, tomatoes, raspberries. Again, fava beans, sauerkraut. Those are common ones that typically a lot of patients have in their diet or access to, so those are why they become more relevant. So again, and this is another tool at thisiswhy.health that you can download, give to your patients, use it for your own, educational purposes to help, protect them from this if they should be put on a medication that has monoamine oxidase inhibition. All right, now we need to talk a little bit about monitoring parameters. Well, hopefully at this point, you can predict most of what that's going to be. Now, just like any patient who comes in, you're always assessing their mood, their psychiatric symptoms that originally were the reason you put the patient on or they qualified for a monoamine oxidase. But that can also include side effects like changes in sleep patterns, anticholinergic effects, dry mouth, constipation. Those would be things that would be relevant. Obviously, from a vital sign physical exam standpoint, monitoring that pulse, blood pressure, looking at changes in their weight, right? Dietary compliance, that's a big one. And then looking for new medications that could interact. Just again, like I told you at the beginning, when I was learning about warnings and interactions, this class shows up a lot. And so it's kind of like the HIV medications. They interact with everything, seems like, right? So it should humble you enough to pause and not make any assumptions, but constantly be vigilant to look out for this so that patients don't experience inappropriate side effects that we can prevent up front. All right, what about counseling? Well, compliance with the medication is key. If you are using the Selegiline transdermal patch, it needs to be applied to dry, intact skin, not damaged skin, typically to the upper torso, upper thigh, outer surfaces of the upper arm. So that's really important. You want to also change it out, that transdermal patch, same time each day, but rotate the site. Now, unfortunately, Selegiline patches can contain some metal, potentially some aluminum. So if you have to have an MRI, you need to remove it before going into the MRI suite. Okay, so we talked about compliance. Compliance not just with the medication, how to use the right dosage formulation, but also remember that food, the tyramine containing foods. Now, if they are going to start another antidepressant, they need to be told up front, counseled extensively, to wait that 14 days before starting the new prescription if they're coming off of the monoamine oxidase. If they're going to be initiated on monoamine oxidase inhibitor, we got to wait at least a week, possibly 2 weeks or longer in patients on Prozac. Now, over-the-counter medications, people don't pay attention to those a lot. Sometimes they ignore them. But don't forget about herbal medicinals like St. John's wort or even some decongestants. Again, this is an enzyme. It's going to prevent the metabolism, and we know that St. John's wort has antidepressant properties, and decongestants can influence some of that catecholamine response and adrenergic response on vessels, which is why they're being used. All right, guys, that's a lot. And sometimes drug classes like this seem less of a priority because, we don't see them used very much, and I'm just scared of them, so I'm not going to touch them. I understand that. And at the same time, like I said at the beginning, we need to be able to recognize when these drugs are appropriate to use and their issues. Okay, we don't just see one patient all at the same time throughout our career. There are multiple patients who come in with different issues, different backgrounds, different side effect profiles, risks for side effects because of genetic polymorphisms and other medications and comorbidities that they have. So pharmacotherapy is about picking the right drug for the right patient, the right indication, to reduce the exposure to side effects and adverse outcomes while achieving the goal. And so our patients depend on us to know that why so that we know how to manage them appropriately. If you found this to be helpful, I encourage you to go out to the website thisiswhy.health. Again, we have some collections, playlists. You can bookmark, save things, you can download tools. You can also sign up to get newsletters and updates for future topics and things that we roll out to help anybody that's in need of that kind of information. All right, so the monoamine oxidase inhibitors have a lot of clinically relevant issues, mostly centered around drug-food and drug-drug interactions that can result in significant side effects, but they work. They do work well and can be good, viable options for treatment-resistant depression. So make sure that you recognize which ones they are. Recognize that Selegiline dosage formulation issue. That's, again, a good test question for boards. Oral, remember, is Parkinson's. Transdermal is for depression. Those nuances, again, can be very relevant. All right, if you're watching this on YouTube, please like and subscribe. We appreciate that. And we'll see you next time on the topic review in pharmacology. Take care. Bye-bye.